Hello, everyone. Let me start by saying thank you for inviting me today to talk about my PhD project. So the title of my presentation is the BoriZafi Project, Bridging the Gap in Sickle Cell Pain Care. So I would like to proceed by acknowledging that I'm joining you today from the University of British Columbia, which is on the traditional, ancestral, and unceded territory of the Musqueam people. So I'll proceed in my presentation by talking about sickle cell disease. So I'm just going to give a brief overview of what sickle cell disease is, and then I'll talk about my research, my research project. So sickle cell disease is a group of inherited disorders that are caused by mutations in the beta globin gene. Now, there are different variations to these mutations, resulting in different types of sickle cell disease. For instance, we have the HBSS or the HBSC. The most common is the HBSS, which is also known as sickle cell anemia. Now, in sickle cell disease, what happens is that the hemoglobin molecules are abnormal, and that causes the red blood cells to assume a sickling shape when hemoglobin molecules releases oxygen. Now, the sickle cells are sticky and they have a shorter lifespan and are often responsible for the numerous complications and symptoms that are associated with this disease. And a very cardinal characteristic of these cells is that they would clump together and cause vaso-occlusion in smaller vessels, resulting in what we call sickle cell crisis or vaso-occlusive crisis. But in this presentation, I'll be using the term sickle cell crisis. Now, people living with this condition, they experience a lot of different types of pain. And in my research, I will be focusing on sickle cell crisis in adolescents specifically. So what is sickle cell crisis? It is a recurrent and unpredictable episodes of moderate to severe acute pain in people living with sickle cell disease. And anybody who has seen anyone experiencing sickle cell crisis will tell you that it is excruciating. It's such an excruciating, painful episode. And it's usually self-limiting, and a typical episode can last for about 7 days on the average. And it is the leading cause of hospitalization in young people living with sickle cell disease. It can also lead to different complications such as multi-organ failure, acute chest syndrome, and even sudden death. Experts recommend that sickle cell pain should be managed with pharmacological and non-pharmacological intervention. This information is very key to the rest of my presentation. Now, people living with this disease often report that their pain is misunderstood and poorly managed. And usually, the pharmacological treatment would involve opioids and non-opioids, depending on the context or the country. I would say, from my experience, the country that the person living with the disease is seeking care. Now, due to the distress associated with this condition, there are numerous physical, psychological, social, and financial consequences. And for instance, there's diminished overall quality of life for the patients and their families. And there's also the societal stigmatization. Stigmatization is very key because there are reports that they even experience stigmatization from healthcare providers whenever they go to the emergency unit and seeking opioids for pain management. And there's also a huge financial burden associated with this disease. In some countries, like Nigeria, that I'll be talking about briefly, there is often no insurance to cover medical expenses, and so expenses are covered out of the pockets, and this can be a huge burden to patients. Approximately 7.7 million people are living with this disease globally, and a huge burden of the disease is in sub-Saharan Africa. In Canada, it is the most common blood disease, and there are more than 6,000 people living with the disease in Canada. It is considered a rare disease, actually. But it is the most common inherited blood disease in the country. So my research was conducted in Nigeria, and Nigeria is the epicenter for sickle cell disease globally. There's an estimated annual birth rate of 150,000 babies. However, the improvements in sickle cell management care has not really improved as we loved it to be. And this is due to numerous challenges affecting the care for people living with this disease. My research was focusing specifically on these two obstacles, which is one, the use of unhealthy interventions such as body scarifications, and also addressing the limited access to evidence-based interventions such as safe and effective non-pharmacological interventions. So I present to you the BoriZafi Project. We are using a patient-centered approach to develop a culturally appropriate pain toolkit that is called BoriZafi. And BoriZafi means overcoming pain. It's a combination of two Nigerian languages. This toolkit will educate adolescents on safe and effective non-pharmacological interventions that they can use whenever they have sickle cell crisis. In this study, non-pharmacological interventions refer to any intervention that is non-medicinal and non-surgical that is used by adolescents to manage sickle cell crisis pain. Now, to develop this toolkit, it was necessary to conduct a couple of preliminary studies. So first, we did two scoping reviews, one focusing on patient-oriented research and another one focusing on non-pharmacological interventions used by adolescents globally. Then we did a survey in Nigeria. Followed by that, we did an interpretative description study, which is a qualitative study, interviewing adolescents, caregivers, and also healthcare providers. And then we did a Delphi survey involving 20 experts from all over the world, giving us ideas regarding safe and effective non-pharmacological interventions that can be included in the pain toolkit at the end of the day. And then the development of the BoriZafi Sickle Cell Crisis Framework, which basically provides information on safe and effective non-pharmacological interventions that can be used whenever adolescents have sickle cell crisis. So these are the preliminary studies that we've done prior to developing the toolkit. So for the sake of time, I'll be focusing only on one of the scoping reviews and then the survey and also part of the findings from the qualitative studies. Now, whenever I give presentations, I like to think of, something that is familiar and then try to attach it to the new information that I'm given. I want to believe that many of us might be familiar with the evidence-based practice framework. It is a common framework for clinical decision-making that integrates the best available research evidence with clinical expertise of the clinician and the patient preferences aimed at improving patient outcomes at the end of the day. So as I go on in my presentation, I will be highlighting these three components in relation to managing sickle cell crisis pain in adolescents. So the first study that I'm going to talk about is this scoping review in which we systematically identified evidence on the use and effectiveness of non-pharmacological interventions for pain management in the pediatric population. So we searched 9 databases and we identified 27 different studies. Most of these studies were conducted in the United States. None was conducted in Canada, by the way. And we also got studies from Nigeria, Brazil, Australia, and Chile. We identified 27 different interventions, and the most commonly used ones were prayer, massage, and distraction. We also looked at experimental evidence to see if there's any studies out there that explored the safety and efficacy of many of these interventions. And the conclusion that we reached was that there are inconsistent results regarding the effectiveness of interventions such as virtual reality, guided imagery, and cognitive behavioral interventions. Now, this study played a key part in understanding the best available evidence that is available with regards to this topic. So the next thing we did was to conduct a survey in Nigeria. We targeted adolescents aged 12 to 18 years across the country, and the aim was to determine the types of non-pharmacological interventions they use to manage sickle cell crisis and their preferred medium for receiving educational resources on NPRs. So we included 123 surveys in the analysis, and this aspect of the project gave a very good understanding on patient preferences and needs. And when I share the findings shortly, you would see what the patients prefer. We asked them if they had used any non-pharmacological interventions in the past 1 year. And 77% of them indicated that they had used at least one non-pharmacological intervention for pain management. And the top interventions were massage, herbal products, prayer, heat application, and then sleep and rest. And one thing we found is that most people tend to use more than one intervention. They tend to use different interventions together. Now, it's worthy to know that many of these interventions have not been researched, and it's unclear if they are effective for managing sickle cell crisis pain specifically. And some of these interventions, like the herbal products and concussions, they might actually be harmful because sometimes people just mix different substances together. They have a concussion and then they drink it, believing that it could help with the pain. We also asked participants about the interventions they would like to use in the future. 52% plan to use at least one intervention. And the most common was herbal products. And this is really important. Again, this is the reason I mentioned earlier on. Many of these interventions have not been researched. And from this study, we also realized that there was a challenge that the adolescents indicated. They stated that healthcare providers did not approve the use of some of these interventions. And they would love to use them during hospitalization, but oftentimes healthcare providers do not approve the use of this intervention. And again, I'm going to point out one of the statements I made earlier on, that experts recommend that this pain, the sickle cell crisis pain, should be managed with non-pharmacological intervention as well as pharmacological interventions. So we decided to speak to healthcare providers to understand what the real issues are, because we cannot develop an intervention that is opposed by healthcare providers. At the end of the day, it's just going to be research waste. So we spoke to healthcare providers and we recruited clinicians that provide direct care to adolescents experiencing sickle cell crisis. And the questions we asked them really focused on exploring their perception about non-pharmacological interventions, specifically for sickle cell crisis pain, and the interventions they recommend, the ones they don't recommend, and the barriers they face whenever they want to implement or recommend these interventions. And this portion of the research helps us to understand the clinician's expertise in relation to using or recommending these interventions. Now, these are the emerging themes. I'm going to discuss the emerging themes from this data. We identify 5 themes. So the first one is negative perception. So this theme describes participants' negative impressions about non-pharmacological interventions. Some clinicians believed patients came to the hospital for medical treatments and not to receive non-pharmacological interventions. And as a result, it was not relevant in the hospital. And some felt it was unrealistic to use these interventions for managing sickle cell crisis because of how excruciating the pain can be. And also another person also indicated that, if this intervention is effective, then it could be an indication that the person is actually faking their pain. The next theme was opposed NPI. So the interventions that healthcare providers opposed. And these include herbal products and concussions, and also body scarification. So body scarification is when they make marks on the body and then put substances in it, believing that these substances can help with the pain or help with releasing bad blood, as some patients reported. So this was a major issue because some of the healthcare providers described experiences in which patients either developed sepsis as a result of these interventions, or in this particular transcripts, in this particular quotes, the physician explained that the patient actually died because they went to seek alternate medical care with a traditional medicine man. The next thing is recommended NPIs. So healthcare providers, some healthcare providers support the use of NPIs, and they felt that interventions like massage, heat applications, and others could actually help with managing sickle cell crisis. Also, healthcare providers pointed out that they didn't have enough knowledge regarding these interventions, and as a result, cannot confidently implement them when caring for people who have this condition. We also identified numerous influencing factors. One is the severe pain associated with sickle cell crisis, and also the fact that there's a mentality that when talking about, there was a mentality that we identified from the data, that when we talk about non-pharmacological interventions, there's an assumption that we mean this intervention should replace drugs. And that is not possible. You cannot manage sickle cell crisis with only non-pharmacological interventions. It has to be a combination of both non-pharmacological and pharmacological interventions. So now I'm bringing us back again to the EBP framework. So from what I just talked about in the 3 studies that I presented, it is evident that the current research on non-pharmacological interventions, specifically to sickle cell crisis pain, is inconclusive about many of these interventions, and there's a need for more research. And also, when we look at clinician expertise, there's a problem because many of the clinicians do not even know how to implement these interventions whenever a patient has sickle cell crisis pain. And when we look at patient preferences, there are 2 things. Adolescents are using these interventions and they want to use these interventions, but they themselves do not have adequate knowledge about safe and effective ones. And that's why there's a huge preference for interventions like herbal products and concussions, which can actually prove to be harmful. So the next steps for this research, we have done the Delphi study and as well as also developed the framework. The next step would be to develop the toolkits based on the responses from the patients, caregivers, healthcare providers, as well as experts from all over the world. And then I'll conduct a pilot RCT. And if that goes well, proceed to conduct a full randomized control trial. So in conclusion, Nigerian adolescents use various non-pharmacological interventions to manage their pain, including traditional remedies and physical and spiritual interventions. There's a need for research on various NPIs to establish their safety and efficacy. And I will point out at this point that though this study was conducted in Nigeria, this is also relevant in Canada because there are people living with this condition in Canada who go to the hospital, and there's a question about do they want to use some of these interventions in the hospital? Are they using some of these interventions at home and even during hospitalization? And how is this impacting their care? And so there's also a need to have patient-centered educational resources to help address the inequitable access to pain education and care across Nigeria. I'd like to acknowledge my supervisory team and the funding that I've received in the course of my PhD program, and also the Sickle Cell Foundation partners that I've worked with throughout this project. Thank you so much for listening.